Here's the next speaker at this point from Dr. Leah ZAINI, who's going to talk about the management of infectious endophthalmitis.
She's from which country? Initially we have
Thank you, moderator, and thank you for the organizer for having me today. Today, I'm going to talk about the management of infectious endophthalmitis. Okay, I have no conflict of interest in this presentations, and we know that the endophthalmitis is a severe intraocular infection caused by bacteria or less commonly by fungi, and although relatively rare, endophthalmitis remains one of the most severe sight-threatening complications following cataract surgery. The improvement of surgical techniques, shorter operating time, smaller incision surgery, and the use of povidone iodines, also intracameral antibiotics at the end of surgery, make the incidence of endophthalmitis has decreasing in recent decades. This is proved by some study done, conducted between 1999 until 2020 that found there is the decrease in incidence of endophthalmitis in recent decades. So I'm gonna focusing about the post-cataract surgery endophthalmitis. So talking about the management of endophthalmitis, it means that talking about the endophthalmitis vitrectomy study, which is still the reference standard, evidence-based reference for management of endophthalmitis. And their recommendations is early vitrectomy in endophthalmitis was only beneficial in patients with vision of light perception or worse. However, we also know that the additional research is needed to complete this study because the choice of treatment strategy based on the presenting visions may not be always reflected the severity of inflammations. There is widespread of availability for generation of fluoroquinolone, and the advances in vitreous surgery have become safer than before, and then EVS was not recruiting grossly infected eyes, and the systemic antibiotic use in EVS were only amikacin and ceftazidime. So these are the causes that current practice pattern deviates from the recommendation of EVS. But are there any other conditions that also need to be considered for the management of endophthalmitis? So we know that there is some study conducted between 1919 until 2020 that have a similar finding with what EVS finding. But let's take a look at my country, especially my province, in Aceh. Maybe we have a similar conditions with my province. I don't know, but we in Banda Aceh, in Aceh, with approximately 5 million people there, these retina and infection and immunology services only available in Banda Aceh, which is the capital city of Aceh. And Aceh is a province with most populations has financial limitations, limited hospital facilities, limited number of retina and infection services, and also limited availability of drugs. So we accepted referrals of endophthalmitis patients from all districts. And we have some problems with most patients have limited funds for medical treatment, and most patients do not have enough time to treat and regular control, and most patients come with very serious conditions. Maybe because of the time it takes from when the patient is referred until they arrive at our hospital is quite long. So this is our data from 2022 until 2024. As we can see here that most of our patients or post-cataract surgery endophthalmitis. And the more older the patient, the more frequent endophthalmitis patients. And for the comorbidities, most of the patients have no comorbidities, but diabetes mellitus is the most frequent comorbidities found in our patients. And for the spectrum of bacterial, we have a little bit different with other Western countries, maybe which Pseudomonas species is the most frequent bacterial isolates from the vitreous. So we also know that management of endophthalmitis protocols are to eradicate or control infections, managing the inflammation and supportive therapy. But I think we have the other point to be considered, like we have to do the fast management and use only facilities available at the hospital and consider the cost incurred by the patients. We can see this, most of our patients come with very severe visual query. 88% come with visual query with no light perception, and hand movement. And most of them cannot come to control regularly to our center. Only 69% of the patients can come to follow up until 1 month. So I think this is the most important reason why we have to choose the fast management for our patients. So we choose complete early vitrectomy study and endophthalmitis management study as additional reference to managing the inflammations. CVE recommended for doing complete early vitrectomy for fundus obscuring acute post-cataract endophthalmitis, and endophthalmitis management study use quantifiable inflammatory score instead of the presenting visions to allocate for surgery. And there is another study that have a similar result with what's HVE and EMS finding, like study by Bloom et al., Najafabadi et al., Tabatabai et al., and Feng et al. So surgery, as I said before, were our protocol to treat the severe endophthalmitis post-cataract surgery. Even EVS concluded that early vitrectomy in endophthalmitis was only beneficial in patients with vision of light perception or worse, but it seems to be no longer relevant because surgery can reduce the bacterial load, toxin, and inflammatory mediators, and then removal of vitreous as a growth medium of bacteria, improve retinal oxygenation, allows direct inspection of the retina, and advance in surgical technique make the vitrectomy result is safer than before. And vitrectomy reduces the severity of the disease and accelerate visual rehabilitations as our patients expected. So to eradicate and control infection, I think we have the same thing to do with other center. We give the local antibiotic like eye drops and also the intravitreal antibiotics, and also giving systemic antibiotic of 4th generation fluoroquinolone. And for managing the inflammations, corticosteroid is still the most potent anti-inflammatory agents, and we can give it systemic, topical, or also intravitreal. And also supportive therapy, like giving the cycloplegic agents, glaucoma medications as needed. And this is our protocol. For severe bacterial infections with fundus obscuring and intact cornea, we give the patient systemic antibiotic and topical antibiotic at the initial presentations, and then doing early vitrectomy with intravitreal antibiotic, and then take the vitreous specimen for the culture, and then continue the systemic and topical antibiotic. After we get the result of culture, and then the antibiotic are adjusted according to sensitivity result. This is the management of our patients. About most of our patients underwent partial vitrectomy and intravitreal antibiotics, and I think this is quite effective because it can reduce the very bad visual acuity from 88% until 50%. So other point to be considered that we use silicone oil control to eradicate and very severe infections, but our problems are if the infections has subsided, the patient have to come again to our center to undergo the evacuations of silicone oil, and of course this is the problem of most of our patients. And in case of post-cataract surgery endophthalmitis, we perform IOL extractions in most cases. And this is also a problem for most of our patients because they have to come again to our center to do the secondary IOL implantations. So as the summary, EVS is still the reference standard in the management of endophthalmitis, but further evidence is needed to refine the EVS findings, and microbial conditions and demographic characteristic of endophthalmitis patients is in various countries are not the same. These differences should be taken into considerations in management of endophthalmitis. Thank you.
Thank you very